So I think moving into the theme of PCORI, we're going to change gears a little, but it is thematic. The next three talks are about areas that are extremely difficult to study, but also extremely important to all of our experience, particularly the patient experience with any kind of cancer, but especially so cholangiocarcinoma. It's my great pleasure to invite one of my colleagues from UCSF to give the next talk, Dr. Mustafa Arain, who's an associate professor in the Department of Medicine and Division of Gastroenterology, and also a very specialized hepatobiliary endoscopist who performs very advanced procedures and cutting-edge techniques for biliary obstruction. And so, again, hearkening back to the themes of PCORI, this is an area that's extremely difficult to study, but integral to our management of patients. And I'm thrilled to hear your talk today, Mustafa.
Hi, and first of all, I'd like to thank the foundation as well as the organizers for inviting me. From the minute this event started, it's been very moving and touching, and I think as a physician, I often am on the first line of seeing patients without the diagnosis often, and I'm breaking the diagnosis to the patients, which is tough, but then to see the patients go through various stages, and then to have them come here and be at a forum like this, I think this opens our eyes as clinicians to various aspects of the disease process that you go through on a day-to-day basis. And I think the last talk was very, very instrumental to how we as clinicians should be thinking about patients with the true north being patient welfare. So the topic, biliary management in cholangiocarcinoma is a complex one. And I think the first slide sort of says it all, that it's not a single person or single specialty that needs to handle this. This is a complex process involving GI oncology, surgery, radiology, and gastroenterologists. And it's really a team effort and everybody working together to ensure that we do the right thing for the patient. So the issue with cholangiocarcinoma and biliary obstruction, of course, is that bile from the liver does not drain appropriately. And the difficulty here is that the clinical manifestations may not occur till later on as the disease has progressed, oftentimes too far advanced. So patients may be very asymptomatic. Jaundice may be the initial symptom. Cholangitis, where there is infection within the biliary tree, may be a presenting symptom. And then the symptoms that may present may be very vague, as some of you may have experienced. And these are not specific to cholangiocarcinoma. A patient who presents with jaundice without weight loss, or even with weight loss but no pain, actually can have a whole host of potential diagnoses. And the question becomes, how do we figure out what this is? Predominantly painless jaundice, as clinicians we're taught to think of pancreatic cancer, but as you become more and more focused in the pancreatobiliary field, we see a fair number of patients with cholangiocarcinoma. And on the benign side, primary sclerosing cholangitis, of course, can be a risk factor for cholangiocarcinoma, as was discussed earlier today. So with that in mind, as patients get referred to us, we have to always be thinking outside the box or within the box, but not just focusing on one thing and benign diseases, but thinking of malignancy. This diagram has been shown to you before, just to show that there are different sort of types of cholangiocarcinoma. It so happens that intrahepatic cholangiocarcinomas tend not to present with jaundice, because if there are ducts involved in the peripheral segments of the liver, because of the redundancy in the liver, there may not be jaundice. So really, oftentimes as gastroenterologists, what we're dealing with is perihilar or distal disease, which is what we often have to work up. So in terms of evaluating somebody, what are our options? There are diagnostic tests that are non-invasive, which can give us a lot of information without putting patients through risk of more invasive procedures. And there are a lot of abbreviations here, but essentially I'm going to go through most of these. So MRI and MRCP. Basically, it's an MRI of the abdomen with two different phases. One is an MRI with intravenous contrast, so we're actually allowing the tissues to take up that contrast, and tumors will pick up contrast differently from normal tissue, and that's how we can diagnose those. So the second phase is the non-contrast phase, which is the MRCP part, which allows us to look at fluid during MRI, and the ducts light up very nicely. The entire biliary tree can be evaluated, and this helps with both figuring out the extent of the disease as well as planning future procedures and surgery. This is also important in terms of planning for surgery and the extent of surgical resection that may be considered, and how much normal liver would be left behind, because this has implications for outcomes after surgery. And here's an example of an MRCP with cholangiocarcinoma, with the duct being constricted in the middle, but the intrahepatic ducts seem to be not involved, and the distal bile duct is not involved either. So that's the value of an MRI. A CT scan is a similar study in the sense that it's a cross-sectional study, allows us to evaluate the liver, organs outside of the liver, such as lymph nodes, and also look at tumors. It also nowadays, with high resolution CTs, we can actually look at the bile ducts quite well, but not as clearly as we would with MRI. Arterial and venous interpretation for non-radiologists like myself tends to be better with a CT compared to MRI, but experienced MRI radiologists are very good at picking up subtle things that most of us can't. Again, it can allow us to evaluate for a future liver remnant. So here's a CT scan, excuse me. Here's a CT scan of a patient with cholangiocarcinoma. Unfortunately, you can see the portal vein as it goes into the liver, it's getting compressed. And these are factors that need to be weighed in when surgery is being considered. And here's the mass causing compression. So we get a lot of detail. So what about the invasive procedures? The role of invasive procedures prior to any consideration for surgery is actually quite controversial in the literature. You wouldn't think it from what really we experience in terms of patient care. I think part of it's cultural. In Asia, it tends to be that they prefer not to do invasive procedures so much, whereas in Europe and the US, it tends to be preferred to get a tissue diagnosis, and therefore that involves invasive procedures. The consequences of biliary sort of obstruction are that there's impaired liver function, increased risk of biliary obstruction, and impaired cellular immunity. So the rationale for these invasive procedures is that if we can reverse these effects of biliary obstruction, then perhaps we can improve outcomes. But again, based on the literature, there is discrepant data with some studies clearly showing worse outcomes post-operatively if we are too aggressive up front, whereas other studies showing better outcomes if you can get liver function resolved. So there isn't a clear-cut answer. Having said that, intrahepatic patients tend not to require biliary drainage because there isn't much in terms of biliary obstruction. The big controversy comes in the area of the perihilar tumors, right, where that area where Katie mentioned earlier today too, you have the blood vessels and the branching of the main ducts that involve significant segments of the liver. And the other component to this is that it can be difficult to drain the different ducts. Distal bile duct cholangiocarcinoma theoretically does not require drainage. Patients, if they have resectable disease, should be able to go to surgery. The difficulty is that it's hard to differentiate pancreatic cancer from cholangio, and in these settings, oftentimes we end up doing surgery. The other sort of implication for transplantation is that any invasive procedure that crosses the barrier between the ducts and the outside of the liver precludes transplantation. Whereas in the lower duct, that doesn't apply because this whole area of the bowel and the pancreas and the bile duct comes out. So we have to be careful and thoughtful in who to recommend invasive procedures for. So along those lines, there is a classification system which you may be aware of in terms of how to differentiate the types of cholangiocarcinomas based on the extent of involvement of the bile duct. And basically, as long as it's in the main duct, it's relatively easy to deal with. As the tumor creeps up the ducts towards the liver, it becomes more complex. And I'll show you some examples of these as we move forward. So the advantages of drainage, knowing all this background, well, symptomatic relief is a significant one. Patients who are jaundiced maybe, and you may have already experienced this, have itching and discomfort, poor appetite. So any relief that we can provide, improved liver function prior to surgery. The thought being that by improving the function, there is better regeneration after surgery of the liver remnant that's left behind, and tissue acquisition at the time of biliary drainage, which may help with the diagnosis. Disadvantages: introduction of infection from our procedures, complications both from endoscopic and percutaneous procedures, primarily infection, but also bleeding, risk of tumor seeding, and all kinds of procedure-related specific complications. And just, I'll show you more images, but this is an ERCP where you have an endoscope injecting contrast dye into the ducts, and this is coming from the outside through the skin into the ducts. So I'll just give you some examples here of various situations where intervention of the ducts may or may not be indicated. So this was a patient with cholangiocarcinoma, with dilation of the right side of the liver, the ducts. There's an abnormality here in the lower duct, who was referred for an ERCP, but actually there was no jaundice. The patient had a normal bilirubin. So instead, the patient was evaluated with an endoscopic ultrasound, and outside of the liver, right here, which is called the porta hepatis area, there was a lymph node that I sampled, and it came back positive for adenocarcinoma. And the picture fit adenocarcinoma, and therefore we did not expose the patient to the risks of ERCP, and she actually underwent a right hepatectomy. This is a patient where it wasn't so clear as to exactly the extent of the disease. Is this very advanced disease in the form of stage 4, bismuth 4, or whether it's a bismuth 3 lesion? This is an MRI. The right side ducts are dilated as well as the left, and here you don't see much of the ducts. Unfortunately, this patient actually did have an ERCP with no significant improvement in jaundice or very good drainage, so was referred for radiology. And I'll come back to why there wasn't good drainage. But a percutaneous drain was put in from the right side as well as from the left side, and showing that this is stage 4 disease, bismuth 4 disease, and therefore unresectable disease, and the patient got external drains for their biliary obstruction. And this patient had an endoscopic approach first. There was a question of whether this is bismuth 2, just involving the hilum, or 3A, because the right side ducts don't look as enlarged as the left system. And in this patient, the diagnosis wasn't also confirmed, so there was a request to obtain a diagnosis. So ERCP was performed, and one of the newer, not sure how to play the video here, but can you play the video in the back for me, or? So thank you. So this was actually, it's a cholangioscopy procedure where we, under ERCP, advance the camera inside the bile duct. And this sort of what's described as nodular appearing tissue with blood vessels is very characteristic for cholangiocarcinoma. So apart from visualizing and getting a clinical suspicion, we can also obtain biopsies at the same time. and these can then help confirm the diagnosis. Now, for full disclosure, these tumors, as you probably know, are very hard to diagnose even with biopsies, because sometimes the surface may look abnormal, but actually they're creeping under the surface, and so these biopsies don't have a 100% pickup rate. Once ERCP is done, we can obtain biopsies either directly under endoscopic visualization or under fluoroscopic visualization, as shown here, and then a stent can be placed, and this patient had a right hepatectomy too. So endoscopic treatment prior to surgery is one thing. I mean, the idea is jaundice resolution, targeting healthy ducts, and avoiding lobes and segments. But there is a role for endoscopic treatment, unfortunately, when surgery is not possible. And there, it's really important for physicians treating patients to ensure that they have a good understanding of the anatomy, because appropriate drainage will result in better outcomes. We have multiple choices in terms of stents, plastic or metal. If in doubt, always put in plastic stents. And the reason being that they can be removed. They come in different sizes and different materials, and they need to be placed deep into the ducts to ensure that there's a good response. And the image that I showed you earlier, where these stents are just coming up to the branch point, isn't enough. These stents need to go in deep and need to be long. So these are longer, larger caliber stents deeper into the various liver ducts. In terms of metal stents, these are in situations where surgery is not possible. These definitely tend to be more challenging in terms of deployment. There are different types of metal stents available, and they can be put in side by side or one through the other in what's called a Y stent configuration. In terms of outcomes, the big difference is patients who receive plastic stents because of the smaller caliber, need more frequent ERCPs for stent exchange. Metal stents have better patency, but it's really the disease process that determines prognosis in terms of longevity and survival. Either can be revised, and outcomes are dependent on ensuring that good liver segments have been drained, the healthy ones, and also that the risks of infection have been sort of reduced by doing so. So here's a patient who was, Katie and I actually shared, there was consideration for a right hepatectomy. However, it was later discovered that there was advanced disease. So initially treated with plastic stents deep into the right anterior and left segments. And then we had a discussion in our multidisciplinary clinic together with the patient and her family, and discussed the benefits of metal stents over plastic stents, and placed a left-sided stent first, and through that mesh placed a second stent. Her disease was actually creeping down into the main duct, so I had to do a distal stent as well. The other sort of just for informational purposes, the cost of a plastic stent is about $50. The cost of a single metal stent is about $2,000. And if somebody is repeatedly having plastic stents changed, just don't hesitate to ask the physician, is there a reason why you can't do metal stents? Because if you're getting tired of plastic stents, or your loved one is, then I think metal stents have definitely been shown to reduce the need for procedures and overall improvement of quality of life. So I think that's something that as awareness of that becomes more prevalent, then we can do the right thing for our patients, for you. So what's new and maybe gives us some hope? This radiofrequency ablation probe, which has been around for about 5 to 6 years now, it's basically localized current to burn and ablate tumor tissue, developed in the UK and is available in the US for the last few years. And basically, the probe goes over a wire into the bile duct under fluoroscopic evaluation. So this is a patient who had metal stents, and then tumor recurred within the stents. So the probe was used to basically ablate tumor in both the stents. And just this month, there is a randomized trial out of China, which has shown that stent patency in unresectable patients, as well as survival, and it's in the order of months, about 8-month differential, but may be improved in patients who do get treated with radiofrequency ablation. It's a small study, about 40 patients in each arm, but that's encouraging news as we try and deal with this very difficult and complex disease at multiple levels. At a localized level in the ducts, we could certainly consider doing this on a more regular basis. So in summary, we do require a multidisciplinary approach, do the right thing for our patients. Drainage is not always necessary before surgery, but when it is necessary, we have to ensure that we get the right parts of the liver drained. In non-operative situations, I do think that overall patients from a quality of life perspective do better with endoscopic stents as long as they've been done right versus percutaneous drains. And there may be hope even in the field of endoscopy for localized treatment of these tumors. And with that, I'll conclude my talk. Thank you.
Any questions for Dr. Arain?
Start out with plastic stent for the microphone. I started out with plastic stent. I read about metal stents. Back then, they were saying that they were kind of, you can't remove them, it would damage you, and it's inoperable. Well, I didn't know if they meant that particular place where the stent is inoperable, but now they have plastic covered metal stents. So when you talk about metal stents, are you always talking about plastic covered?
Yeah, so when the duct lower down, when it's like a single tube, like the main trunk of the duct, then we can do covered metal stents. Because one of the advantage of a covered metal stent is that the plastic coating prevents tissue ingrowth. But if you put it high up in the liver, it's gonna block the drainage of the little branches of the ducts inside the liver. So the general rule is that if you're going above the bifurcation, the split of the ducts, then you should only do uncovered metal stents or plastic stents. But if you're staying below the bifurcation, then covered stents can be done. So if you were told that metal stents don't work, I don't necessarily agree with that.
No, it was kind of like they have to stay put forever and you can't get them out without possibly injuring yourself.
That's true. So uncovered metal stents are permanent. The difference is that they allow you to have less procedures. With plastic stents, you need ERCP stent exchange every maybe 2 to 3 months, sometimes less, sometimes more. With metal stents, what multiple studies have shown is that the time interval between ERCPs will be reduced. So the first time around, from the time you put them in, people can go up 9 months to even longer, sometimes shorter. And the other question was, well, once you put them in, you can't really do anything about it because now you're stuck because there's metal all over. But given the appropriate techniques, one can open the stents back up. And now with the radiofrequency ablation, that's a modality that we do use to clean out the stents, like if there's any debris buildup inside the ducts, and then use radiofrequency ablation to sort of reset the clock and prevent putting in new stents.
One quick question. I had a patient, another cholangio patient, say that they had a blockage that it was solid. And so they were saying there was nothing they can do. Could they do radio ablation for something like that?
If it's from the tumor, yes. Sometimes the degree of obstruction is so severe that we may not be able to get a wire from below at ERCP, but those are the situations where radiologists can come from above because those ducts will be distended from above. And then they can come in and typically, because they're so much closer right at the skin level, they can get their wire across. And once they have achieved that, a few weeks later, then we can work with the radiologists and internalize that so that we can go back to avoiding putting an external drain in.
Okay.
So to answer your question, yes, it's doable, but it requires some effort.
Okay, thank you.
Mm-hmm.
Okay, you mentioned jaundice and different things are obvious symptoms for a blockage. Is there anything like a bilirubin counter in the labs that would kind of show a change that there might be a blockage happening?
Yeah, absolutely. The earliest sign is actually not even the bilirubin, but some of the other liver enzymes, the AST, ALT, just either going up or just fluctuating. They may go up, come down, and not really, have a real fixed pattern or fixed progression. But that could be the first sign of there being something obstructing the duct.
Okay.
Beyond that, symptoms-wise, pain, fever, chills, shakes, cholangitis, so those are the things to look for.
Okay.
Bilirubin in revision cases tends to go up later on.
Okay.
Yeah.
Thank you.
Mm-hmm.
Can you address ERCPs in people who have had a Roux-en X
Yeah.
procedure? And some people get them. Some people are told they can't have them because of the complexities of the new
Yeah, actually,
anatomy.
I'm going to be giving a second talk. I think that's supposed to be more for the scientists.
you?
That's on Friday, and I will bring in some images of that for you. But the reality is, it can be done. The difficulty is it's time consuming because it takes about an hour and a half or so, sometimes just to get to the anastomosis. So it's very center dependent. If there's somebody who takes the interest and time to do it, it can be done. And
I've had it done, and I know other people who have been told not
Yeah.
to. Yeah, and it was like a 2-hour procedure versus a
exactly.
30-minute procedure.
Yeah, but the difference is if you can pull it off, as you probably know, then you can avoid having to put in the external drains, and it's improving quality of life. So I think it's doable. The other sort of shortcoming of the enteroscopy approach for the Roux is that we don't have as many accessories for those scopes, for the very long scopes. But the different companies are working on longer accessories to give us a broader sort of spectrum of devices that we can use. But if it's a matter of stretching a stricture which may be benign, especially in a Roux anastomosis, then we do have enough there that in the right sort of setting it can be done.
So go somewhere where there's an expert.
Yes, there's someone
versus-
who's willing to do it, yeah, and spend the time.
Thank you.
Can I just one more question? If Katie is doing a study and she needs to follow the tumor size and so on, does that affect your choice of metal or plastic stent?
Kit, you can tell me, but not necessarily. I don't think our stents, clearly with the metal stent, even with the plastic, I'm told that, for radiologists it can be hard because even plastic stents can induce inflammatory changes. But I think we have to balance that against clinical sort of, doing right for the patients from a clinical perspective. So I think the burden of having repeated procedures is quite significant. And in my opinion, based on the literature, the benefits of metal stents outweigh the risks. And there are ways to biopsy the tissue if necessary, even with metal stents, which we have done. And we can, yeah, absolutely. And there are, MRI and CT can still be done to evaluate the disease process.
Okay, thanks.
So thanks so much, Mustafa, for the excellent talk.